The member for Higgins.
Thank you, Deputy Speaker. I'd like to thank the member for Goldstein for raising the profile of this important issue and for her local advocacy, and I would like to thank the other members of the chamber for sharing their testimony. There is clearly bipartisan support in the House to fix this vexed problem. What is key to fixing this problem, however, is listening to the front line, in this case our constituents, and to the lived experience and the families who have gone through this problem. But I'm here also to share my experience as a senior clinician at the Alfred, where I, as a senior generalist, managed patients with eating disorders, principally anorexia nervosa, who were at the most severe end of the spectrum. These patients were overwhelmingly female. They were sometimes children, even though we are an adult hospital. They were in their late teens, and my oldest patient was in their 30s. These patients came into the hospital always in crisis. They were close to death. Because a hospital like the Alfred it's not just a tertiary hospital, it's a quaternary hospital, and we looked after the most severe cases. And I had patients who had BMIs as low as 11. To put that into context, a healthy BMI is 19 to 25. So you can just imagine what a BMI of 11 actually looks like. These females, these women, sometimes teens, were fragile. They were fragile physically, but also in their minds. And it was really, really challenging to look after these patients. One of the hardest, hands down, the hardest group of patients for myself and my teams to manage. Not only were they skeletal, their arms and legs were like twigs, but always cloaked in baggy clothing, warm clothing, because they were unable to regulate their temperatures. And it was very, very challenging to form a therapeutic alliance, because that is what we strive to do as clinicians, to form a therapeutic alliance with our patients, but also their families, because for these patients were in the grips of this disease, and they rebuffed all attempts for us to try and make them better. So it fell to a multidisciplinary team to try and manage them, and at the head of that was someone like me, a senior clinician who had to make the tough decisions and sometimes be the bad guy in the room. So I signed off on some pretty restrictive practices, I've got to say, things like tube feeding, things like sometimes mechanical restraints in order to put the tube down. And we would often do blood tests twice a day to make sure the electrolytes were not going haywire. And in some cases, in actual all cases, we would start off with the patient just being in the ward with a standard nursing ratio, but it would always escalate to requiring a nursing special in order to watch over the patient to make sure they weren't purging surreptitiously or hyper-exercising, which happened a lot, or indeed self-harming. So it was a really, really difficult problem. We had daily consultant liaison psychiatry input. Dietitians would come twice a day, and we also had social workers seeing patients and their families, because often that relationship was damaged, it was fractious, and it was very, very difficult for families to watch what was happening, and they had that sense of powerlessness. They were unable to turn a ship around. So where things went wrong actually was not in the hospital. These patients had intensive ward-based care. Sometimes, despite our best efforts, they would end up in intensive care. But where things often went wrong were in the transitions between hospital and the outside world. It was very difficult to find step-down care units, and that is something our government is trying to address. So we are committing to over $258 million towards fixing this problem, which has been neglected. And it's been neglected basically because it's rare, because it's gendered, overwhelmingly affecting females, and it's complex. We're really good as a health system in fixing simple things like a broken arm or a broken leg. We are really, really bad at fixing complex problems that require multidisciplinary care. And this is all the more reason why we are also committing to $13 million towards the Centre for Research Excellence, which is already open at Sydney University, the Charles Perkins Centre. and $20 million towards community-based eating disorder support units, the kinds of supports I never had as a doctor. Thank you, Deputy